I'm going to palpate here in the front just to see if I can feel any crepitus. And for the female, okay, you're going to kind of go down this way. Okay? And again, I'm going to feel here. Any tenderness, I don't feel any swelling. Okay. I don't feel any red, there's nothing red anywhere. So that's the palpation of the chest. Okay? Part of the palpation of the chest also is doing two things, right? The excursion and also doing the fremetus. Next, what I'm going to do is I'm going to do the fremetus. Okay? He's going to repeat for me, your awful hard iron. He is going to repeat. He is going to repeat 99. When he does that, he's actually vibrating his lungs. And I want to feel that vibration on the ulnar surface of my hands. Okay? So, it should feel symmetrically even all the way down and diminish in the lower lobes. Okay? If it doesn't, okay, one of the lungs may be congested, consolidated. All right? So I'd like you to repeat 99.
99, 99, 99, 99, 99, 99, 99, 99.
Okay, hang on. We'll do it on the front. Go ahead.
99, 99, 99, 99, 99.
And that's what I felt. I could feel the vibration until I hit the lower lobes and it was diminished. Okay? The next thing that we're going to do is diaphragmatic excursion. And you can do it anteriorly, but I always do it posteriorly. Doesn't matter which way you want to do it. Okay? What we're doing diaphragmatic excursion is what we're trying to look at is if he has symmetry of that diaphragm when he takes a deep breath and when he exhales. Okay? I usually go about T10. Okay? What I'm going to do, I put your thumbs together. And what I'd like you to do is take a nice deep breath, blow it out. Okay? And he has symmetry, right? My thumbs are going in and out symmetrically. So his diaphragmatic excursion is very symmetrical. You can do it anteriorly if you like, but I find that it's much more distinct if you do it in the posterior area. Okay? Now, the next thing that you're going to do is you're going to percuss. When I percuss, what you do when you percuss is you're vibrating the organ. Okay? You want to vibrate that organ. And when you percuss, you want to get a sense of the density of the organ. Is it solid? Is it full of fluid? Is it hollow? And the sound that should be emanated when you percuss the respiratory tract, okay, should be resonance. Okay? So, when you're percussing, there's two ways to percuss. Okay? You can use your finger like this, so to speak, okay? But I don't get a good sound because my hands aren't strong. You can also use a reflex hammer. Okay, this doesn't hurt you anymore, does it? You don't feel it any. It's just creating a better sound for me. So when you percuss, okay, you go from side to side so that you can compare. And I can hear some resonance. And it certainly diminishes, right, when I get down in the lower lung field, right? Okay, can you lift your arms up? Okay. Okay, down. And again, you have to percuss the front, okay? In the same way. Much more resonant. Of course, he's a male, so he doesn't have the breast tissue that females have. Kind of dull there. Etc. Okay? So that's the percussion. Okay? Now, auscultation. All right? When you're listening to somebody's lungs, obviously we want to listen. And the other thing that I didn't do earlier, which we needed to do, which I missed on the exam, which I just realized it now, is we needed to count the respiratory rate when we were looking at the chest. Okay, we needed to count the respiratory rate, right? That's in the early part of your exam, for a full minute. And we need to look at the character, right, of the respiratory rate. It's 14, it's regular, there's symmetry of the chest when the person breathes, no use of accessory muscle, okay? Now when you're listening to breath sounds, what you have to remember to do is focus in on the normal sounds and where they are, all right? So normally you're going to hear tracheal sounds over the trachea, bronchial sounds over the bronchovesicular, over the mid-upper airway, and also bronchovesicular right upper posterior lung. The rest will be vesicular, okay? So when you're listening to breath sounds, listen for that long inspiration and short expiration in the vesicular sounds, the short inspiration, the long expiration on the tracheal or bronchial sounds, or the equal inspiration and expiration on the bronchovesicular. Okay? Take a nice deep breath. Now they're vesicular up here. Long in, short out. Bronchovesicular, that right. Still vesicular and clear. Still vesicular. Good. I'm going to listen in the lateral. All vesicular, long inspiration, short. Okay, you want to take a break so you don't get CO2 dizzy. The next thing I'm going to do when I come to the front, I'm going to listen up here, take a breath. Bronchovesicular. Pretty even there. Even inspiration, expiration, and then tracheal. Very hollow sounding, short inspiration, expiration, etc., etc. Listen down in here. Breath sounds are clear. Certainly doesn't seem to have any inability, right? He's not stressed when he's breathing. I hear no adventitious breath sounds. I hear no wheezes, crackles, or slash rowels, bronchi gurgles, whatever you want to call them. I hear no adventitious lung sounds. So when you're doing your exam, you have to talk like this, because we don't know if you just stand there and listen what you're hearing. Okay, so the descriptors are important. So have I covered everything on that? Nope. Vocal resonance. Vocal resonance is, again, the person repeats 99 whatever you choose. It can be blue cow, whatever. And what you do is you're listening for that 99. You're listening to that. And what it should sound like is kind of muffled. Okay? If it sounds clear, they're consolidated. So the first piece of that is bronchophony. What I'm going to have you do is repeat 99.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Now, it sounds muffled, louder, and diminishes in the lower lobes. That's the normal. Okay? When I listen to the front, same thing.
99, 99, 99, 99, 99, 99, 99, 99.
Again, same thing. It's not a clear 99. It's kind of muffled. That's the way it should be. And then it diminishes in the lower lobes. Okay? And next is the whispered patriloquy. Same scenario, except he whispers it. Okay? And it again will sound diminished, muffled, and diminish in the lower lobes. So whisper 99. Hang on. Good. Here. Okay. Again, that's the whisper. The last one is egophony. And with egophony, you want the person to repeat E, E. And the E should not sound like A. If the E sounds like A, it indicates that they have COPD. Okay? E.
E, 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 E,
Hang on. Okay, move on.
E, 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 E.
So, normal. Okay, it sounds like E all the way through. So his vocal resonance is pretty symmetrical, muffled, which it should be, and diminishes in the lower lobes. So that's the end of that exam. Okay, did I forget anything? No, it's not on the list. Yeah, I know what you mean. Okay, the next thing we're going to do is the heart. Okay? Now with the heart, first thing that you're going to do is you're going to inspect again the color, right? Because if you get this system again, we'll do the whole deal again. His color is generally pink, okay? The next thing that we're going to look at is we're going to look at whether we can see in the chest his heart pulsating. If you see the heart visibly pulsating in the chest, it usually indicates that they have cardiomyopathy, all right? Enlarged heart. The other thing that you're going to be looking at is sometimes over the auscultatory landmarks, right? Second intercostal on the right, second intercostal on the left, third intercostal Erb's point here, fourth intercostal, right? The tricuspid, and fifth, the mitral. You're looking at these areas for any heaves, lifts, okay? Any vibrations, any pulsations, and I don't see any of that. Now my next piece is going to be to palpate, okay? So I'm going to go over my auscultatory landmarks, my second intercostal, and I'm going to see if I can feel a pulsation, a thrill, anything, a heave, and I don't. I'm going to slip over to the second intercostal on the left, and I'm going to listen or feel again, I'm sorry, for any heaves, thrills, etc. Then I'm going to move down to the third, and I don't feel anything. I'm going to move over to the tricuspid. I don't feel anything. And then over to the mitral. Now, when you get over to the mitral, or the point of maximal intensity, which is mid-clavicular line, fifth interspace, you should be able to feel a PMI. Have you ever felt yours, Clinton? I got it. So you should feel it, but it's pretty brief, discreet, and it only has like a diameter of 1 centimeter where you can feel it. So you have to kind of fish around a little bit, so to speak. So I feel his PMI, okay? Okay. Now the next thing that we're going to do is we're going to auscultate heart sounds, right? With the type of stethoscope that I have, you're going to listen with the bell and also with the diaphragm. For today, because we don't have that much time, I'm just going to listen once. And if you have a stethoscope like this, you just press lightly for the bell and harder for the diaphragm, okay? So what you're going to do is you're going to listen over the auscultatory landmarks for, again, are you hearing any murmurs, extra heart sounds, anything out of the ordinary, okay? Because that's what we're listening for. Split heart sounds, if those of you are good at that. Now remember, S1 is closure of the tricuspid and the mitral, and S2 is closure of the aortic and the pulmonic. So, remember that when you're listening here, the S2 will be much louder because it's right over the valves that are closing. When you're listening to S1, it'll be much louder here, okay? So I'm just going to take a listen. The dub, and definitely the S2 is louder. Definitely louder. Have you ever listened to that on yourself? And then I'm going to move down to Erb's point, and still the S2 is still loud there. And then I'm going to move down to the mitral. Now, S1 is more prominent. And at the PMI, I'm going to take his apical pulse for a minute. S1 is prominent. So, his heart rate is 66. It's regular, medium pitch, with no abnormal heart sounds noted, no murmurs, no rubs, no S3, no S4, no, okay, all the abnormalities, all right? And that's what you have to say for that piece. Did I miss anything? Nope. Okay, peripheral vascular. First of all, when you're doing peripheral vascular, that's kind of an extensive topping there, I noticed when I looked at it. But when you're looking at peripheral vascular, of course, you're going to be looking in particular at the extremities. You're going to be looking at the color of the extremities. Are the color of the extremities pink? I'm just going to take one of these off you if you don't mind, Kenton. So I'm going to be looking at the color of the extremities, okay? And the next thing that I'm going to be looking at is I'm going to check the temperature of the extremities with the back of my hands. So the temperature certainly seems to be warm, quite warm, because we're both dying of heat here. And the texture is very soft, okay? He doesn't have a rough texture of skin. So that's the first thing that we do. The other thing that we need to look at when we're looking at peripheral vascular system is we really need to zone in on whether there's an arterial problem. So when I'm looking for an arterial problem, if I would make his legs dependent like this over the edge of the bed, he would have rubor, right? If he had an arterial insufficiency, those bright red hot looking legs. And the other thing is he wouldn't have hair on his legs because people who have arterial insufficiency don't have enough blood flow for the hair to grow on their legs, okay? But that certainly seems intact. Now, if Kempton had a venous problem, venous insufficiency, then what would happen is he'd have a lot of edema and brown pigmentation on his legs. And I don't see any of that on Kempton. And remember, the place that you're going to check for edema on individuals, I usually start in the pedal area, then I go around the malleoluses, and it'll have a tendency to go right around the tibia. Sometimes it goes right up here. And remember, if you have a partner that has edema, remember the scale to use. 2 millimeter depression, 4 millimeter depression, 6 millimeter depression, and 8 millimeter depression. That's the new scale that we use. 2 being 1 plus, etc. Okay? Now, the other thing on the first part of that, as I recall, I'm doing a general circulation check, but when I check his pulses, I'll really be able to assess the circulation. The second piece is motion. I'm going to check his motion in a few minutes when I do the walking or whatever with him, okay? But obviously, if you're doing this system to check motion, then you would have him move his extremities, put his arms up and down for you while you're doing this exam, okay? Sensation, when you do sensation on anybody, you need to have them shut their eyes, okay? And what I'm going to do, Kempton, is I'm going to ask you whether this is sharp or dull.
Sharp. Dull. Sharp. Dull. Sharp. Dull. Dull. Or sharp. Sharp.
You cheated a little bit there.
It's sharp. Dull. That's sharp.
Like a test question.
Yeah.
Okay.
It's dull. Sharp. Dull. Sharp.
Etc. Okay, that's the sensation. You feel that. Okay, part of that piece. All right? Now the next thing that we're going to do again it seems redundant, but we're in a different system. We've got to check also, again, capillary refill should be under 3 seconds. Clubbing, right? Nail angle should be under 160 degrees. And again, you can hear. Circulation's on good now here. It's cold. Okay, cold there, but hot everywhere else. Okay. Now, the next thing that we're going to do, because we've checked first, we've checked, kind of palpated a little bit. The next thing that I'm going to do is I'm going to check all of his peripheral pulses. You must remember how to grade them. 1 plus being diminished, 2 plus full, or normal, 3 plus full, 4 plus bounding. Remember, when you're checking somebody's carotid, you don't want to do both simultaneously unless you want to give them a stroke. Okay? And it's about 2 plus. I'm going to check the other side. Remember to do bilaterally everything when you're doing a system like this. Okay, 2 plus again. And you can do them to save time together. And this is about 3 plus here. Brachial. Femoral, which I'm not going to do on him. He's been good enough. That's right in the panty line right here. You're going to have to check them on your person, though, when you're doing the examination. Okay? Popliteal is a little difficult. Sometimes if you take and bend the leg, let me have it there, Kenton. And then you can feel it. And it's okay if you don't during examination, because a lot of times this is very difficult because of the folds of skin to find it. Pedal. Oh yes, this is good, even though your foot's cold. 2 plus. And posttibial. Okay. Pedal, posttibial, popliteal, femoral, radial, brachial, carotid. Okay? And the last thing that you need to do as far as the pulses is we need to do the check for a bruit with the bell of our stethoscope. Remember, a bruit over the carotid means that it's narrowed. And it sounds like a swooshing, murmur. And I don't hear a murmur, or a bruit, I should say. Okay. And last but not least, we want to do the Homan sign, okay? And instead of making him lay down, he should truly be laying down, okay? Now with the Homan, again, we're checking for phlebitis, right, inflammation of the calf. You want to flex the foot, put some tension on it. And I like to feel it as well. Is there any warmth there? Does it hurt when I do that? So he's got a negative Homan's on the left. Just do this like this. And negative Homan's, okay, on the right. Remember to do pulses both areas, even though I didn't get his foot. Okay, his other foot. So that takes care of that system. Did I forget anything? Okay. Mouth and throat. A favorite of all of ours. Now, first thing you're going to do is look at the mouth. Okay? Lips are pink, smooth, symmetrical, horizontal. That's the way they're supposed to be. All right? When you examine the mouth, you really, really need to put gloves on. Now the next thing that I'm going to do is I'm going to check his teeth. Even though the outline is kind of out of sync, I didn't write it. But I always go from the outside in. Okay? So the next thing I'm going to do is I'm going to have you smile, and I'm going to look at his teeth. Look at his teeth. Nice teeth. Okay, so his teeth are white. They certainly look symmetrical. I'd like you to open up your mouth for me. And the surfaces are smooth, firmly anchored. I'm going to also be looking for caries, periodontal disease. I don't see any of that. Firmly anchored. Okay. Gums, I'm going to check those in a second. Looks good. Okay. The next thing I'm going to do is I'm going to check his gingiva. Okay. Gums. Look at your gums. Okay, they're pink, stipple, tight tooth margins. I don't see any periodontal disease. I don't see any redness, swelling. Beautiful. Okay. Next thing I'm going to do is I'm going to look at his tongue. Okay, stick your tongue out at me. What you get is cranial nerve. Well, okay. It's dull red. There's papillae in the back. Can you lift your tongue up? Okay. Where's your frenulum? Right there it is. Frenulum is centered. You'll see vessels that are prominent. You look at the roof of the mouth because you want to make sure there's no lesions. And stick your tongue up. Let me look at the size of your tongue. Okay. Oral cancer is really up and coming. It really is. So you have to really check. Okay? Now the next thing that I'm going to do is I'm going to check the buccal mucosa. Okay, the inside of the mouth. Check in your mouth. Okay, it is pink, it is clear, I don't see any lesions. Good. Okay. Now the other two areas that you need to check are, you need to check the hard palate and then the soft palate. Just open your mouth. The hard palate is dome shaped, transverse rugae. The soft palette is light pink and right